start. Gives me pleasure then to introduce Dr. Frank Penedo, PhD. Dr. Penedo is a clinical health psychologist with postdoctoral fellowship in psychosocial oncology and behavioral medicine. Dr. Penedo is the Associate Director of Cancer Survivorship and Translational Behavioral Services at the University of Miami Miller School of Medicine and the Sylvester Comprehensive Cancer Center. Dr. Penedo co-leads the Cancer Control Research Program, and his work focuses on the role of sociocultural, biobehavioral, and psychological mechanisms underlying disease activity and health outcomes, studying the efficacy of evidence-based psychosocial outcomes. Dr. Penedo is a past president of the International Society of Behavioral Medicine. Welcome.
Thank you. Good morning. It's a great pleasure to be here and to have an opportunity to talk about some of the work in the context of cancer survivorship relevant to communication and health literacy. I want to just provide some background information on cancer survivorship, although many of you are familiar with this. We have seen an unprecedented growth in the number of survivors, of course, particularly due to early detection and advances in treatment. In fact, there's about 16 million cancer survivors now alive. That number is expected to increase to about 20 million by 2022. I also like to qualify the term cancer survivorship because that's one of the challenges that I think we have, is that the NCI and other organizations define a cancer survivor as somebody who's been diagnosed with cancer. So from the point of diagnosis on, the individual is considered a survivor. So there's been a lot of emphasis on survivorship, research, and care. Unfortunately, the survival benefits that we see are offset by multiple challenges that these patients face: chronic late effects, chronic treatment-related side effects that lead to significant functional and interpersonal challenges. Because cancer primarily is a cancer of older individuals, we see populations with a significant number of comorbidities, which of course create more complexity. And care tends to be complex, expensive, it's often fragmented, and there's a significant financial burden associated with cancer treatment. It's not surprising that about a third of cancer survivors report significantly elevated psychological distress. Of course, this varies by prognosis, disease stage, and premorbid functioning. And most of the psychological distress experiences anxiety and depression. But for the most part, psychologically, most cancer survivors do relatively well. Well, given these collective challenges, the National Academy of Sciences and Legacy Institute of Medicine put out several very influential reports that raised awareness to the fact that we as a field really had placed limited attention to the needs of cancer survivors. We really didn't do a good job at dealing with the physical, social, emotional, and financial consequences, and that care coordination and continuity was a major, or continues to be a major challenge for cancer survivors, and there's been more recent emphasis on cancer care delivery research. So I'm going to talk about briefly about 4 essential areas of survivorship care in the context of communication. Of course, this is not a comprehensive list, but for the sake of time, I'm going to focus on symptom monitoring as one area, and then as continuity of care, lifestyle factors, and comorbidities as another area in the context of survivorship care planning. We have been fortunate that accreditation bodies have pushed standards that require us to implement certain practices that address the needs of cancer survivors. So for example, these are American College of Surgeons Commission on Cancer standards, which require that every cancer patient undergoes a psychological distress screen at a pivotal point during their care, and that there is a documented discussion with the patient regarding how they scored on that psychological screen, and also that we provide a survivorship care plan, which is a comprehensive document which includes a treatment summary, follow-up guidelines, and to some extent, lifestyle factors, how to deal with comorbidities and other possible risks to prevent recurrences or secondary cancers. Revisions are coming for this. It's not a very well-kept secret. It looks like now we're going to require that every patient is assessed during active treatment. So they're giving us more specifics on when to do the assessments. And it looks like the survivorship care plans will become optional, which is something that many cancer centers would probably welcome, as many of us have been struggling with meeting this mandate because of the complexity of that document. So if we look at the cancer control continuum, cancer survivorship really, in the way we think of it and traditionally think of it, starts after the end of treatment or primary treatment. But if you look also at what takes place at diagnosis, like care planning, palliative care, psychosocial support, this all falls under the umbrella now of cancer survivorship, at least in many cancer centers. And now with the definition of survivorship being at the point of diagnosis, this creates several challenges. And how do we deal with this term? How do we deal with implementing these services? And more importantly, how do we effectively communicate this to the patient when they're coming in for a diagnosis and we say, oh, by the way, you're considered a survivor? It creates confusion at the patient level, it creates confusion at the provider level, and that's one of the challenges that we're dealing with. So how do we engage patients in survivorship care? We have several programs, which many cancer center programs have, which will provide informational materials explaining what survivorship is, what to expect, when to expect, reach out for those services. Discussions typically begin post-active treatment. In some cancer centers, they begin 2 years after active treatment, so there's quite a bit of variability in this, but some have argued that earlier might be better. Particularly, obviously, for patients with, who are treated with curative intent to create better engagement. One of the major challenges in many survivorship programs is engaging the patient once they've completed primary treatment. You give them a call, you tell them we have a cancer survivorship program, and it takes a lot of effort to explain at that point why they're being contacted about survivorship when they're still going, for example, adjuvant treatments. Survivorship also implies for many 5 years post-treatment, completely cured of cancer. There I even say, is there a better term that we should be using? We should probably think about this a little bit more carefully given the challenges that we face. And then we have the challenge of lack of provider education and or understanding of survivorship care, to the extent that in some cases we get resistance from providers. And this is the case particularly with hematologic cancers for good reasons. A lot of those providers don't want to be focused on survivorship care at the point of post-transplant unless they have a good understanding that self-management, self-care, follow-up care is all part of the survivorship experience. And then we have cultural and contextual barriers, of course, that our patients can face, and they can also interfere with patient engagement and the understanding of survivorship. And I'll give you a couple of examples on that. So talking about symptom monitoring and management, there's been a lot of attention recently to focusing on patient-reported outcomes. We know it's essential to capture these patient experiences through the patient's participation through the cancer experience. And we also know that the clinicians' ratings of patient symptoms tend to be lower than those reported by patients. In fact, patients tend to do a better job at telling us how they're doing, particularly in constructs like pain, fatigue, and overall physical functioning. And the benefits of capturing these patient experiences or patient-reported outcomes have been well documented. So we know that it can promote better individualized patient care because the patient and the provider can be better aware of what the patient is experiencing in terms of symptoms. It can enhance the patient-provider communication as the patient is informed, as well as the provider, and it can facilitate also shared decision-making and help patients measure progress over time. This is also very aligned with value-based care, which is a concept that we keep hearing more and more within many health systems, where teams really have to think of how do you address the entire patient experience within the care setting, and how do you engage the patient through technology and in a way that it doesn't affect the clinical workflow so that you still can provide efficient and cost-effective care for our patients. So the way that we're doing at our cancer center, this is a very early stages of the process, is that we use the patient portal to facilitate communications between the patient and the provider in the context of capturing these patient experiences. So what we do is that we administer specific questions. Many of these are promise questions, which are very brief, well-validated, computerized adaptive tests for various key domains in functioning for cancer survivors, like pain, fatigue, physical functioning, and of course, depression and anxiety to meet the COC standards. We also include some items from the PRO-CTCAE, that's the Patient-Reported Outcomes Common Terminology for Cancer Adverse Events. We allow the clinics to also put in specific measures if they'd like, if there's something that they want to capture through the patient portal. And of course, we ask about practical needs like transportation, childcare, and nutrition, which is the most endorsed need that we have from our patients. We typically administer this no more than once per month to reduce patient and clinic burden, and we never start at the first visit. We always start at the second visit because the first visit tends to be more distressful for the patient. And the overall functionality is that ideally the patient will do this through their patient portal at home, but the penetration of these portals is 40% at best. So a lot of these patients are going to have to complete this at the clinic, and that's where you have to negotiate with administration and workflows, different ways or different touch points where you can do this. So we have a variety of options where the patient could either do it at the waiting room, or they can do it within the clinic room where there's a hyperlink where the patient can access the assessment. Of course, we would like this to be briefer than what it is, and it'll probably end up being briefer. This is a pilot program that we're launching, but right now this can take anywhere between 6 to 20 minutes, depending on patient literacy, as you would expect. This is what the screens look like. We're trying to make them more patient-friendly. In my opinion, they're too busy. There's too much wording. But on the left, you have the promise CAT. So the patient basically selects one of 5 categories, and after 46 items, we get a pretty good sense of where they fall in our continuum, where you can have a clinical threshold and see if the patient is above or below that threshold. And then we have practical and psychosocial needs assessment. We're now working on the patient-facing form of this. So right now, the patients can see their responses. They can see what they selected at any time. But we're working on making this more user-friendly, prettier for the patient to create more patient engagement. And from the provider perspective, symptoms that are elevated are communicated to the provider. It's not a great image, but what basically shows is the patient how they're doing in depression and anxiety over a couple of months. And if they're in the green zone, it means that they're in normal levels. So this patient has resolved anxiety, but they're still somewhat depressed. So that's how the patient or how the provider can see how the patient is doing. And the provider can actually click on this and see the specific items that the patient endorsed in these questionnaires. So that's one way that we're trying to improve communication from a patient-reported outcomes or symptom management perspective. Another area that we're trying to enhance communication and the patient-provider exchange is through the use of these survivorship care plans, which is really a teachable moment for the patient where we can engage the patient and tell them that we are not only mandated to do this, but it's a point where they've completed their primary treatment, and it's a good point in time in their care continuum to discuss follow-up, lifestyle factors, comorbidities, transition to primary care, if that's going to be the case. I'm not going to go through all of this, but this highlights the comprehensiveness of the care plans, which is a problem, especially for patients with low literacy, where we're throwing at them a lot of terms and a lot of areas that they have no idea of what we're referring to. And at least I haven't seen a lot of work looking at the efficacy of these care plans, particularly with lower SES, disenfranchised, or racial ethnic communities. So if we think survivorship care as these services that can be started to be engaged from the point of diagnosis, some of the questions that arises is, can we begin these discussions at diagnosis to promote better patient engagement and better understanding? Are there different points over treatment where we can do this? And we've moved somewhat towards this. We've told patients coming in that have localized disease that following their primary treatment, they're going to be engaged by a survivorship clinic or a survivorship provider. But we still have a lot of work to do. The way we communicate this, we have pamphlets, we have newsletters that we send out, and other printed material that's distributed to the patients within the clinics. So I wanted to see if there was data out there, particularly over the past several years since these guidelines have been implemented for care planning and for better communicating how patients are doing over time. This is a very recent study that assessed whether the quality of the patient-provider communication had increased between 2011 and 2016. It's a study that was led by Ray at the ACS with 2,200 patients. And if you look at the bars here, so shorter bars are better, higher bars are bad. So that's a percent of cancer survivors that did not receive detailed information from any clinician. This is not only from the oncologist, this is from any clinician. So when you're talking about long-term effects, lifestyle recommendations, and emotional and social needs, we're still less than 50% of those patients are getting detailed recommendations on these specific areas. Cancer treatment summary, it's a little bit closer to 52%, probably aligned with the Commission on Cancer guideline to provide that survivorship care plan. In terms of how do we and what areas do we cover in terms of communicating with cancer survivors, there's a lot of work that actually has looked at what is the effective way of communicating and what are the areas that need to be addressed. So we try to address responding to emotions, obviously not only through screening, but in the clinical, in the patient-provider exchange, exchanging information and enabling self-management. Managing uncertainty is probably an area that's not as well developed. However, there are some studies that are taking place looking particularly at patients coming in for molecular profiling or patients about to enter phase 1 trials where uncertainty becomes a central issue for them, not knowing what are going to be the benefits of those treatments for them. But those studies are still relatively limited. But in any case, there's quite a robust literature of showing what techniques and what methods can be used to enhance communication with cancer survivors. In terms of the racial and ethnic minority communities, this is a study with breast cancer Latina women. 50% of them were uninsured or had low socioeconomic status. Most of them, unfortunately, had late-stage presentation and diagnosis. They attributed some of this to linguistic and cultural barriers that they face. Of course, they raised issues regarding spirituality, familial roles, or passive interactions with healthcare providers, which we know are all cultural processes within Hispanics and somewhat similar in African Americans when dealing with the health system. But specific to survivorship, they expressed confusion regarding future care needs after primary treatment, and they also misinterpreted what survivorship care, and they thought it was more about plans to help their family carry on after they were gone. So it was a lot of misunderstanding with the whole concept of survivorship, and again, a lot of social and cultural determinants that are shared by other racial and ethnic minority groups. So in my work, we've done quite a bit of work at adapting interventions and framing messages to racial and ethnic minority communities. We've worked a lot with Hispanics. I just wanted to provide some examples of how we communicate or how we frame messages in the context of communication for survivorship. So, for example, we know that familism is a cultural factor that tends to be common in Hispanic and other collectivistic cultures. The implication here is that there's a strong attachment or interdependence with the family. And the psychosocial implication is that the patient is not going to see a benefit from what's being offered to them or a benefit out of engagement unless they see a benefit to the family. So we reframe the message as identifying how engagement in proper care is going to benefit the extended family or their role as a provider within the family. And the way we frame the message is in the importance of self-care to maintain a strong family. Another cultural factor that stands out significantly, and it's been mentioned several times, is simpatia, or this lack of assertiveness or the need to maintain positive interactions where you don't disrupt the provider-patient exchange, you don't question the provider. If you don't understand what they're saying, if it's above your head, you still stay quiet because it would be disrespectful. There are several approaches and skills available out there. The belief approach, which is basically asking the patient to get a better understanding of what caused their illness, have them explain to you why do they think this is happening at their time. Speaking about fotonovelas and telenovelas, many decades ago, I'm not going to admit that I was watching a soap opera, but the villain died of breast cancer because she was a villain and she was a bad person. So again, we have this culturally embedded patterns of thinking that cancer is a bad thing, something that we're being punished with. But in any case, this is some of the techniques that are available from a culturally informed care where we can ask the patients themselves to give us a better understanding of how do they perceive their illness so that we can work with them in a sensitive manner. So just to wrap it up, some recommendations is to establish and implement clear guidelines for timely introduction of survivorship care, clarify or perhaps revisit the terms we use with our community so that they're better accepted, educate both patients and providers, and foster a health system culture of survivorship. Sometimes we have our advanced level providers contacting patients, introducing survivorship, and then they could get to an oncologist and say, you're not a survivor, you're under adjuvant treatment, you're not 5 years off primary treatment. So we have to align ourselves in those efforts. I think culturally informed and targeted approaches need to be implemented to optimize patient engagement. And I think finally, I don't know if we need another R1 type of study to show the effectiveness of communication interventions and how they have favorable outcomes. Perhaps we need to start moving more towards dissemination and implementation in large-scale studies in health systems to see how systematically improving communication can foster these favorable outcomes. So thank you. And